I'm really excited to be here. Every time somebody says I've been here 20 years, I've been here 22 years, I'm like, where was I? I wish I had been here. It really seems like the kind of conference that I should have known about for a lot longer, but now I do, and I intend to come. So the goal for what I'm going to do is just set the stage in terms of bringing a different voice into this conversation and bringing the voice really of the public, of many of you who are providers. It's the people you serve every day. Those of you who are policymakers, it's the people your policies are impacting every day. In trying to just get a better sense of what their priorities are and what they think about healthcare as we talk more specifically about what's happening at the states. I'm going to stay focused on the kinds of issues that the states can actually make a difference in. So for example, I was actually very pleased to see that so many of my Medicare for All data points already got put into the discussion because I didn't include them in this presentation. And so I'm not going to talk about Medicare for All because although some states like California or some other states have talked about things like that, that really is a national discussion right now. So with that said, let's see if I can make this move. I am going to focus almost completely, how does it go forward? It's push. Yeah, that's what I'm hitting.
Great.
Oh, wait, maybe it's this way?
Oh.
Okay, now
like
I got
my
it.
husband says, reboot
right,
or
now we
turn
go.
it upside down.
Got it. Turns out the right arrow and the left arrow are the same arrow if you have the thing upside down. Okay.
That's okay, that's not in your wheelhouse,
Yeah,
right?
no, that's not what I do. All right, so why do we do public opinion? We spend a lot of time and energy at doing this at the Kaiser Family Foundation, and the point that's really relevant for today's conversation is point number 4, and that's that I don't think that the public necessarily is right. I wouldn't say that policymakers or any one of us in here should go out and run and only implement that which the public says it likes. But I do think it's important for us to understand where our audiences are, to understand what's actually happening in people's lives. And it shows us where leadership is needed, our own leadership, and also where public education challenges exist. And so I'm going to use mostly national data today, even though this is a state-based panel. I have a little bit of data from California, and I had some data from Arkansas, but I was afraid to leave Maryland out, so I didn't put it in. But we'll mostly talk about national data, but in the most part, these opinions, these experiences are universal if we looked at the individual states. So I want to start with their priorities. So we talked a little bit about this morning, but when we asked the public just in January what they wanted to see Congress, the new Congress, take up in terms of healthcare. Let's just focus on the total line, the total for now. You know, this issue of costs, rises to the top. So lowering prescription drug costs, protecting people from surprise out-of-network bills is right there in the top 3. Continuing the protections for pre-existing conditions, which also has come up. And then repealing and replacing the ACA, but it comes up as number 4, and it's the smallest share of the public. What's important, I think, to take away from this chart, though, is how much bipartisan support there is for this cost issue. Now, healthcare costs is nothing new in terms of the public's priorities. Whenever there has been any health reform debate in this country, if we ask them, why do you for reform? Why do you want to see change happen? When you follow up, what they always say is we want our healthcare costs to go down. And it's not the nation's healthcare costs, for those economists who are still in the room. It is their own healthcare costs. It's the amount they're paying for healthcare. And it's a perennial worry. And it's something that we're going to talk a little bit more in a second. But you can see that these things are definitely popping on the agenda as something that Democrats, Independents, and Republicans all agree upon. On the other hand, you see these 2 issues that I've highlighted in green, and these are areas where there isn't any agreement. So on the Democrats list, you see implementing a national Medicare for All plan hits the top 4, but at 32%, it's much lower down than these other cost issues. And it doesn't show up on the top 4 list for independents or Republicans, whereas this repeal and replacing the ACA for Republicans is still right up at the top for Republicans. And I loved what Joe said yesterday about, or this morning, God, it seems like yesterday, this morning about that mantra of repeal and replace was the Republicans, and now we've got Medicare for all on the Democrat side. And I think this chart completely shows why. But because healthcare costs do keep rearing their head at the top of an agenda, let's drill into them a little bit. Whenever we ask people about their worries, as I said, we usually see that medical cost worries, the amounts they pay out of their pocket, even very predictable expenses like their deductible or their premium, are things that worry people more than other worries that I've highlighted here with the green. So things like your utilities, your rent, your mortgage, your food. Those are not as big financial worries for people as their healthcare worries. What you also see here is how scared people are of an unexpected medical bill. I think that makes sense, right? People hate uncertainty, right? It's just not a part of how people want to live their life for the most part. And so this whole idea that you could get a bill that you actually owe and you had no idea you would owe it is a really terrifying thing for people. So while this concern for healthcare costs has always been there, one thing we're starting to see evidence of is more people reporting problems actually paying these predictable costs. So we've seen evidence that people are telling us that they have more difficulty paying their health insurance premium each month, their co-pays, their deductibles, and of course these shares are much higher for people at the lower end of the socioeconomic ladder. And these kinds of costs have real implications. Of the 26% of people who told us they had problems paying bills, they report things that are actually very impactful on their lives. 5 in 10, I guess it's about half, are telling us that they used up all or most of their savings, they took an extra job, or they worked more hours. 4 in 10 tell us they had to increase their credit card debt, they borrowed money from friends and family. 2 in 10 said they had to change their living situation. 1 in 10 have borrowed money from a payday lender. And again, all of these shares are higher for people who have chronic conditions or who are higher utilizers of the healthcare system, people who are in fair or poor health, and also certainly people who are at the lower end of the spectrum. But this is not, your income doesn't, predict necessarily whether you're going to have a health emergency or a healthcare problem. And so we see the same sorts of problems among middle and upper income people as well. 4 in 10 people actually have told us that they've had a surprise bill that they had to pay. And we heard this statistic earlier today, and I think it's funny. If we start here and I ask people, how big was that bill that you didn't expect? Half of them tell me it was under $500. Okay, well, it's sort of a familiar figure. Well, we took that question that Gallup had been asking, I think, or somebody else had been asking about whether you could afford to pay a $400 bill. And we asked people, well, what if you got a $500 bill? What would you do? And we live in a country right now where over half the public tells us, I'd have a real problem paying a $500 bill. So, 1 in 5 said they'd have to pay it off over time. Another, almost 1 in 10 would have to borrow in one way or another. 2 in 10 say they would outright not be able to pay it, and that's a $500 bill. And you all know the prices or the charges that people are likely to occur if they have a surprise bill after a hospital stay. I guess what the point is before I move on is that these healthcare cost issues are something that we've talked about in terms of the national agenda. We've talked about it as something that policymakers need to take on, but it is something that a number of states are starting to think about and starting to take on in a variety of ways, especially the surprise medical bills. There are a number of states who are talking about actually making some changes in that arena. I think that that's an area where the states can really make a difference in alleviating a lot of public concern. We also spent a lot of the morning talking about prescription drugs. And we saw earlier how prominent the prescription drug costs are as a problem for people. And I think they're showing up on our list as so prominent for a couple of reasons. One of which was the one that Joe said earlier, which is that we constantly are seeing the latest headline of the latest new drug that costs thousands and thousands of dollars, or the latest drug that everybody uses, like an EpiPen or insulin, something that people are very familiar with, costing having an increase in price that's out of control. So there's sensational and headlines everywhere that people are hearing. But I think there's another reason why drugs have such a soft point with in people's concerns, and that's because it's the number one way any average individual interacts with the healthcare system. They interact by getting their prescriptions filled. It's the most common way people interact with the healthcare system. 50% of the public tells us they take drugs on a regular basis. I mean, prescription drugs on a regular basis. I'm in California. And many of them are taking many more, and they're taking for chronic conditions, and they're not seeing their doctors regularly. They're going to their pharmacy and they're getting the drugs filled, and they know exactly what they have to pay, and they know exactly what the price is because they're seeing them so regularly. So it's a very visible issue. So in all of our polling, we found that the public has real conflicting views about prescription drugs. So on the one hand, they really value the product. They believe that they've dramatically improved people's lives. But on the other hand, they have really unfavorable views of the company. On the other hand, they tell us that drug costs are unreasonable, largely because they believe that the drug companies are only charging high prices to guarantee their profits. But many, 74% of those who are taking prescription drugs tell us that affording them is easy, largely because of their insurance that helps cover the cost. But what that means is there still is a significant share of the public, especially those who are taking more than 5 drugs at a time, or those who are in poor health, or those at the lower end of the spectrum, who are having real problems paying, and they're doing real things that can impact their actual health. So 1 in 5 tell us they haven't filled a prescription because of the cost. 16% tell us they've cut pills in half or skip doses of medicine. And those shares double or triple when we start talking about the more vulnerable groups. So I was going to say this is an area, I know more and more states are talking about this area, and I was going to say this is an area ripe for state action, except that this morning everybody was optimistic that there'll be federal action on this topic, so I guess we don't have to talk about prescription drug costs. Good thing that there's going to be federal action, because it turns out that Americans, I think because of all these reasons, kind of no matter what policy you tell them about that might, that's on the table for addressing the prescription drug cost challenge, they think is a good idea, sort of across the board. Yes, negotiate prices. Yes, release more information. Yes, limit the amount. So they like everything from more competition to more regulation when it comes to drug prices. And again, I think it's because this is such a visible issue. Okay, so what about the issues of the ACA? So one of the things that my team, when we were looking through my slides, thought was amazing is for literally the first time in 10 years, I'm not giving a talk that starts with my favorable opposed trend on the ACA. Now, luckily Dean showed it, so you saw it recently. He showed it to you among Democrats and Republicans, but it's an interesting time in that while there's so many ACA-related issues on the table, things that are about the provisions, the law as a whole, this idea of the law going away right now, we're in a period of pause, and it's honestly the first time in 10 years. But as I say, there's these arenas, these provisions in the ACA that are still under constant, we talked a lot about them this morning. And what does the public think about those? You saw on the first chart that pre-existing condition protections was really ranking at the high in terms of people's priorities. Now, it's funny because throughout the whole time of the passage of the ACA, and when we asked people about provisions, we always knew pre-existing protections was a popular provision, but it really honestly never made it to the forefront of a debate until the repeal and replace debate a couple years ago when President Trump first took office. And that was the first time I think a lot of people got this sense that, if this law goes away, then this thing that I just think is important would go away too. And then it further got on the table because of the Texas law case. So clearly it's something that's important to people. It's important to people in a bipartisan way. And it's so important to people that when we followed up and said, well, if it does go away, or if there is, an issue, do you want to see your state do something about this? And in fact, 7 in 10 said, yes, I actually want to see my state take care of this. And that's something with, huge majorities of Democrats and independents, and even half of Republicans. So I know that there are at least 5 or 6 states who are exploring options to do this right now. And it's going to be interesting to watch how the Texas case comes out to see if there's going to be a need for more state action. So I say sort of the biggest way that the biggest program for last, and that's Medicaid. And Medicaid is probably the area where the states have the most impact in terms of the decisions they make and the things that they do. I want to start with a slide that a lot of people get surprised about when I put up. And it's just drawing attention to the fact that I think conventional wisdom and certainly the historical sort of narrative would say that Medicaid was like that, poor relation and that sort of stepchild of the public program, and there was sort of stigma attached to it. And we tolerated Medicaid because we knew we needed it. But it wasn't the bright and shiny. It wasn't Medicare. It wasn't Social Security. It wasn't something else that really drove political action and drove, especially people, to act and get politically active. But if you look here, the reach of Medicaid is actually quite substantial. 7 in 10 people tell us that they have some direct personal connection to the program. 2/3 say that it is personally important to them and their family. 3/4 have a favorable view of the program, and half even think it works well. I think a lot of people are surprised to hear that. And I also think when we actually ask people, what do you think this program's about? Is it more of a welfare program to, help take care of, the poor, or is it a government health insurance program that helps pay for health care? You can see that the majority think of it more as a health insurance program. So I put this as a starting point because I think it really does change the nature of the conversation and the politics around Medicaid. I think that it's time, and I think people who have done this work in the States all these years know this, but from a national perspective, it's really time to start thinking about Medicaid as its, own sort of political football, in that it really would affect a lot of people when you make changes to the program. I think it's because of some of these reasons that we've seen from the very beginning of the ACA debate that the provision about expanding Medicaid in your state was always very popular, and it was popular in a bipartisan way. And even recently, when we asked the people who live in the states that have not expanded Medicaid whether they think their state should expand Medicaid, 6 in 10 say, yes, I do. I think they should. I also think that all these findings sort of taken together help illuminate why we saw the 3 states passing the referendums to expand Medicaid just this past November. I think it's an issue that really resonates with people. Now, a lot of states have been considering, or in the case of Arkansas, have been implementing the idea of work requirements as part of a Medicaid expansion. And I didn't show the slide here, but in the abstract, when we ask people about work requirements, it's a pretty popular idea, right? It just rings true for people. If people could work, then they should work to get benefits. There's nothing inherently it's part of our work ethic as Americans. And in fact, when we asked those people in the states that didn't want to expand their state Medicaid program, how would they feel if it included a work requirement, 68% of that group said, I'd be more likely to support it. So a work requirement can actually apparently at least give you an opportunity to get more opponents on your side to thinking expanding Medicaid is a good thing. But there's a couple caveats here. And in a sense, I'm using the work requirement policy as a case study. These caveats I could be talking about with any of our policy polling, and I'm happy during the discussion to talk more about it. The caveats are that arguments and information matters. In the context of a political debate, that people hear information matters. So in the abstract, or sort of, when you hear about the idea of work requirements, right, 67% support, 28 oppose. But if I go a step further and say, well, what if you heard, and this is one of the arguments that opponents will often make, that the requirement would result in significant number of low-income people in your state losing health insurance coverage. Now, the share that support shrinks to 49, below half, and the share that oppose increases. So the point is that opinion can be very malleable in the context of more information and in arguments. It's one of the reasons why, interest groups and others can be so persuasive in big public debates, because when people hear more information about these things, it really does change, it can change people's views. There's another thing to keep in mind when it comes to work requirements, and that's people have different understandings about the motivations behind it. So there's, many people who are proponents of work requirements say that the goal of them is to help lift people out of poverty. That's why we're motivated to do this. Many opponents will say, no, really, it's a much more practical, cost-conscious decision to reduce government spending by limiting the number of people on the program. And you can see that Americans sort of have divided opinions about which of those two things rings true, which again indicates to me that in the course of a public debate, there would be real movement in what people might think. And probably most important here, and certainly most important in a lot of these public debates, is that in all of our complex health policy debates, a lot of just the basic facts and nuances of what we're talking about are lost on the public. So, for example, here, more than half mistakenly believe that most of those on Medicaid would be eligible for work requirements are currently unemployed. 4 in 10 recognize that many of the people were actually already working. So there's not even a sense of the basic understanding about who's on the program, who's not on the program, how many people this would impact, those kinds of things. So I guess as the states implement or consider this approach, I think they need to recognize that while people sort of generally positively react to the idea, opinions can shift with any potential implication. I think this is really similar to a lot of what we talked about the idea of unintended consequences. You have unintended consequences of policies that actually get adopted, but you also have unintended consequences of policies that get proposed, in that they can generate a debate and actually end up with the population in a very different place than you thought they would be. So just as something fun, and because the conference is in California, and because we have California featured on our panel, we had recently, just about a month ago, done a joint partnership survey with our friends at the California Healthcare Foundation on California's views and priorities of health policy. So I thought it would be important just to add 3 more data points into our conversation today. The first one is that, like we saw nationally, the idea of affordable coverage ranks right there at the top of Californians' priorities for what they want to see their new governor do. But what was, I think, more surprising to us is that when we gave them a bunch of very specific healthcare issues that they could say they thought, the new governor should take up, access to mental health treatment inched above access to care more generally and to reducing costs more generally. And this is really consistent with some other data we've been looking at. And I sort of wonder if we, and I mean the royal we, as in terms of sort of the nation, are at a precipice of a new emerging public priority. I think this sort of finding is somewhat related to the opioid crisis, and we talked a little bit about that, but I also think it's grounded in the changes in stigma around mental health, and also some other cultural and economic forces, including what we were talking about earlier in terms of stagnant wages and in people not feeling like they can have, an efficacy as much anymore. And in California, when we went further and we asked about the availability of providers in their specific communities, half told us that there aren't enough mental health providers, which was far greater than the share that said the same about primary care docs, specialists, or hospitals. And you can imagine some of the regions of the state and some of the populations where that number was even higher than 50%. So as a forecast conference, I'm going to forecast that while we talked about rural health earlier, I think rural health and mental health are the 2 emerging topics that we are all going to be talking about for the next 5 to 10 years. With that, I'm going to leave you with that, remembering that the public cares most about costs. They want everyone to take care of their costs, but they also care about a lot of these other things that states are actually trying to do. So access, pre-existing conditions, Medicaid expansion, mental health, and taking care of other people. So I'm looking forward to hearing what's happening in the states. Thank you.